Hi, this is Dr. Mitchell Yass, and in this episode, I want to discuss the value of symptoms in terms of establishing a correct diagnosis for the cause of your pain or other symptoms you're experiencing. And as I continue to treat people, it becomes more and more evident that the concept of interpreting the symptoms people are experiencing is pretty much ignored. The symptoms don't even enter into the decision-making about what the cause of the person's symptoms are, which seems somewhat bizarre because of the premise that each particular tissue creates a specific group of symptoms, and the best way to interpret what tissue is in distress creating your symptoms would be to interpret the symptoms you're experiencing. And yet, as I continue to treat people, it is absolutely evident that regardless of the specialist that the person seeks care from in terms of establishing the cause of their symptoms, symptoms are just not a factor. It always has been for the past 40 years and continues to be a simple attempt to get a diagnostic test, an X-ray or MRI, and whatever the results are, that becomes the diagnosis. And when you look at the symptoms, I think as I'm treating people and I explain to them how I'm interpreting their body's presentation, I'm not making this up. This is not a theoretical premise. This is, in fact, an empirical demonstration of what their body is telling is the cause of the symptoms they're experiencing. The body's presentation of symptoms is telling you what tissue's in distress. And so when I present to them what their body is showing, even the individual recognizes that those symptoms do not present what you would expect if the positive diagnostic test finding, like a herniated disc, stenosis, arthritis, a pinched nerve, any of this stuff, what to create symptoms. And I kind of wanted to go to different body parts and kind of show you the common types of symptoms the person is describing, and then show you why those symptoms are more representative of muscle in more than 98 to 99% of cases versus the identified, as I said, herniated disc, stenosis, arthritis, or any of that type of stuff. So I just briefly want to go and show you this is how people present to me. These are the things I see. This is what I point out. And then this is the way I treat based on the narrative that these symptoms represented a muscular cause. And these are the particular muscles responsible. And these are the muscles we're going to strengthen and allow to achieve a force output greater than the force requirement of activity, which will stop the muscles from straining and eliciting pain or other symptom and allow for a complete return to function. So if we look at the neck, we'll see like right up here is one of the most common places the person complains of neck pain, right here. And this is a muscle called the superficial is the upper trap, but deep to that is a muscle called the levator scapula. And the phrase levator scapula means elevate the shoulder blade. So what you need to recognize is this muscle is actually not associated with cervical function. It's actually related to shoulder function. Levator scapula, elevate the shoulder blade. So beyond the idea that it actually acts to elevate the shoulder blade, it actually acts to keep the shoulder blade against the rib cage so that the muscles that move the shoulder joint, which attach from the arm to the shoulder blade, can be anchored on the shoulder blade and therefore move the shoulder joint. So if this muscle were to strain, it's going to be more associated with either other shoulder blade stabilizing muscles or maybe a shoulder muscle straining, and it's causing the levator scapula to overwork, which is why it strains and elicits pain in the region that the muscle exists. The confusing part the most is that since it's in the upper trap region, it's associated with the neck and therefore the cervical spine. And when you press on the levator scapula, when I press right here and the person goes through the roof and acknowledges, yes, I've created the pain, I've just pressed on the levator scapula. So I'm always so confused when they were told that it's a herniated disc or a pinched nerve or any of this type of nonsense, how the practitioner giving the diagnosis doesn't say to themselves, well, I'm pressing on the levator scapula and the person is going through the roof. Therefore, I'm going to have to assume it's the levator scapula that's causing the pain, the actual tissue responsible. And what you'll always get back to is the fact that these people are educated and trained to believe that everything comes from the spine and nerve roots and pinched nerves and herniated discs. So they created this wacky narrative. Well, what's happening is that the disc is impinging on the nerve root, and the nerve root that somehow innervates the levator scapula is causing the levator scapula to go into spasm. And there's that absurd process, that absurd presentation. But if you want to look at logic, you would see there's literally no correlation between people having strained levator scapulas and having herniated disc, stenosis, and pinched nerves. There are some people who have them simultaneously. There's people who don't have them at all. There's no correlation between the intensity of the herniated disc, the stenosis, and the pinched nerve and the severity of the strain of the levator scapula. It's all meaningless crap. The fact is that if you then went on and muscle tested other muscles in the shoulder region, you would see they're strained, which reinforces the position that the levator scapula is actually related to shoulder dysfunction. And the only way that you're going to resolve pain from the levator scapula straining is to strengthen the shoulder and shoulder blade musculature. So one of the other things you might find is you might find that the person's shoulder is elevated at the time they're having the pain. Well, if the levator scapula were to strain, or it were to have a balance were to develop where the levator scapula was stronger than the lower trapezius muscle, which is the opposing muscle, which pulls the shoulder blade down, that could allow the levator scapula to shorten, pulling the shoulder blade up and allowing it to lose its ability to stabilize the shoulder blade and therefore strain. So if someone's having pain in that region and I see that the shoulder is elevated, that's a corroborating symptom that it's a muscular deficit. Is someone actually going to try to tell me that the shoulder is elevated because of a herniated disc, stenosis, and pinched nerve? Are we going to just go this route where everything can be said to be caused by that simply because it's found at the time of the symptom? I mean, at some point, you got to say this is ridiculous. Symptoms matter, and they have a legitimate reason for them occurring. Okay, so that's relating to the levator scapula, the neck area. Let's talk about pain in the front of the shoulder, which is a very common situation. So the person will be told that they have a labral tear or they have an arthritic change there. And so that's causing their pain. But the problem with that is that I'll try to press in the front of their shoulder and bring on their symptom. And I'll press kind of right here. And anyone watching this is going to say, yeah, that's where my pain is, in the front of my shoulder. And what you would have to recognize is what I'm pressing on is the tendon, the long head of the biceps. This is the tendon of that muscle that runs between the acromion process, which is the top of the shoulder blade bone, and the upper arm bone. It runs between them and can be pinched in the space between the shoulder blade, the top of the shoulder blade, and the upper arm bone. So when you press on the biceps tendon and I incite your pain, are we now going to say that the arthritic change in the shoulder joint is referring pain to the biceps tendon, or that it's causing the biceps tendon to go into spasm? Or, I mean, at some point, again, you got to say to yourself, this is kind of getting ridiculous. How many people have been treated for arthritis or a labral tear and they still end up with, after all their treatment, having the biceps tendonitis pain because it's a muscular cause? You got to start making sense of this stuff. So you then have to say, well, the indication from palpation, which is to touch somebody, is that they have a biceps tendon impingement, right? It's running through that spot. And what's happening is that as the elbow is raised, the head of the arm bone is rising, which it shouldn't. So it's impinging on this space that sits between the acromion process and the head of the arm bone. And that's where the biceps tendon runs. So what's happening is other muscles in the shoulder region aren't doing what they're supposed to. The rotator cuff isn't dropping the head of the arm bone down as the elbow rises, which frees up what's known as that subacromial space and prevents pinching of the biceps tendon, right? So again, there are going to be muscle tests that will show this muscle weakness. You might find shortness, flexibility deficits of the rotator cuff. You can't bring your arm down to a 90-degree range of motion when rotating inward. There are obvious corroborating symptoms that you have a muscular cause, and yet people will be told it's arthritis or a labral tear just because the guy you went to or the girl you went to is only educated to identify those things. So even if you had biceps tendonitis and impingement syndrome, they don't know how to identify that. That's the thing you got to wrap your head around. If in fact there's a muscular cause, it can't be identified because the muscular deficits don't show up on diagnostic tests. And these people you're going to get your diagnosis don't know how to interpret the symptoms, and they're not educated to identify those types of causes. They're only educated and trained to take x-rays and MRIs, and whatever it says on there, that is what is interpreted to be the cause, simply because that's what they've been educated and trained to do surgery on, right? That's the way this works. We could do this at a lot of different places. The same thing with, let's say, the groin pain and the person being told that it's arthritis of the hip joint. That's kind of an easy corroborating type of symptom to prove that it is or isn't. So if someone's telling you that you have arthritis in your hip joint, which is on the outside of your thigh, and it's creating groin pain, you would have to say, okay, well, if it's from there, let me try to incite the symptom to come on. So if it was on their left side, I'd lay them on their right side. I would take the palm of my hand and I would jam the head of the left femur into the hip joint and see if I can bring on the referred symptom to the groin, because that's what they're telling you. They're telling you that the groin pain is coming from the hip joint. So let's see if we can make it happen. So I'll take my hand and I'll force the head of the femur in, the thigh bone, and see if I can incite groin pain. And if I can, well, okay, well, maybe that makes sense now. The arthritis in the hip joint is causing the groin pain. But what if you do that from here to eternity and you can't bring the symptom on? But when I press in your groin and I press on a muscle that happens to sit in that region called the sartorius muscle, and I press on the sartorius muscle and you go through the roof, then how can you say that that presentation, that corroborating symptom of pressing on the sartorius brings on the symptom you're experiencing, doesn't factor in to what the tissue is creating your symptom, and you're still going to go with the idea, well, they found arthritis or a labral tear in my hip, so I guess that's the cause. This is my point to everybody. And at some point, you're going to have, if you ever want to see your pain resolved, you are going to have to recognize that the symptoms your body is presenting are coming from the tissue that is creating your pain. So if you want to identify that tissue so that you have an ability to resolve the distress of that tissue, you better start interpreting the symptoms and forget this lunacy that just because you took some picture and found some structural variation at the time you're having your pain, it means that is what is causing your pain. The evidence is overwhelming that those structural variations are independent. They've been there for years, decades probably, prior to you having your pain. So clearly there can't be a correlation, because pain comes at the inception of distress of the tissue. As soon as that tissue is in distress, it starts eliciting pain. If you can establish that your arthritis or your labral tear has been there for 6 months to a year or decades prior, then how could you say that's creating your pain? You can't. When I talk about that, there is literally no basis of saying that the MRI or X-ray is accurate. It's in all facets, theoretical, clinical, and scientific. So that's the reason I profess what I profess, that such an intense passion, because it's so overwhelmingly clear. And I've had conversations recently with people. People talk about science as if it across the board is the same. There is theoretical science, and then there's empirical science, and theoretical is modeling. It's saying, well, I, in theory, think this is what's going on, so I'm going to say that's the cause. Well, finally, at some point, you're going to have to put it into practice and see, as I apply that situation, do I get the results I'm anticipating? And if not, then probably what I'm thinking in theory isn't true. Well, clearly the use of the X-ray or MRI to identify the cause of pain has failed miserably over the last 40 years. 130 million Americans, 1 billion people worldwide, nobody getting pain. Now chronic pain perceived as chronic illness. Basically, the planet has been forced to accept that I'll probably have to live in pain for the rest of my life or become addicted to prescription pain medication, which is synthetic heroin, maybe go for multiple surgeries, see a complete degradation of my quality of life. I mean, that's the majority of people. Why? Why? Because it's accurate, because this use of diagnostic testing has turned out in actual working experience to be very effective? Of course not. It's nonsensical. While the interpretation of symptoms, which is at the basis of the Yass method to identify the cause of pain, has found that in more than 98% of cases, the cause is muscle. Muscular causes don't show up. Any of the stuff I just talked about would never show up on an X-ray or MRI. And the people you're going to aren't in a position to identify it. So if those are the cause of your pain, any of those examples I just gave, you're never getting that diagnosis. Therefore, you're never addressing the tissue in distress creating your symptoms. Therefore, you're never going to see a resolution of your pain or return to function. That's it. So the purpose of these videos is to educate. And this video is designed to make you recognize that if you're going to accept a diagnosis without the interpretation of your symptoms being a primary factor in determining what tissue is in distress, you are probably going to be in chronic pain for a very, very long time. So if this is starting to make sense and you find this video helpful, give it a thumbs up. If you like my YouTube channel, Dr. Mitchell Yass, please subscribe to get notifications when new videos are added. If you have some questions and you want to contact me, you could do so by emailing me at drmitch@mitchellyass.com. And if you actually want to proceed with getting the Yass method to help you and you live in Jacksonville, Florida, you'll be able to come to my new facility, which is opening within the next week or two. Or you can go to my website, livewithoutpains.com, livewithoutpains, plural.com, and you can schedule a Yass method Zoom session so that you could get the Yass method anywhere in the world, and you get to pick and choose the day and time that works best for you. So for now, this is Dr. Mitchell Yass wishing you a pain-free, fully functional life. Bye-bye for now.